Welcome to the World Kidney Academy. The World Kidney Academy aims to provide high quality and evidence-based clinical education at an affordable cost to cover the expenses as well as free education and training. This is based on an asynchronous online delivery mode that helps to bridge the time zone difference and thereby provides a platform for learning opportunities to busy clinicians. The World Kidney's teaching and training programs are delivered by experienced clinicians from various reputable national and international centers to enhance exposure to a broad spectrum of clinical experience. The educational modalities include online lectures, video conferencing for interactive sessions, case-based discussions, critical appraisal of scientific papers, problem-solving exercises, and face-to-face workshops. The World Kidney Academy programs are accredited by the American Association of Continuing Medical Education or the European Accreditation Council for Continuing Medical Education. The World Kidney Academy, committed to education and training.
Hi, everybody. Thank you for coming today. I'm Professor Ahmad Halawa, consultant transplant surgeon, Sheffield, United Kingdom. I'm delighted today to present one of the hot topic, which we need to learn about it, which is tissue typing and cross-matching. We got the expert, Professor Ahmad Mustafa. Professor Ahmad Mustafa, he's friend of us, of all of us actually. He's always available and always keen to give us teaching and educate us about this very complex topic. Without tissue typing and cross-match, we can't proceed with the transplantation. And also, this will be the roadmap for transplantation. How do you define high risk from low risk is based on the tissue typing and cross-match. How would you give immunosuppression is based on tissue typing and cross-match. How you select donor and recipient based on tissue typing and cross-match. Honestly, in conclusion, without somebody like Professor Ahmad Mustafa, there will be no transplant. So, Professor Ahmad Mustafa, will you just go ahead and present yourself and share your slides, please?
Yeah, I'll just start with the most common question. Now, do you see my screen?
Yes.
Okay, excellent. Okay, so hello, everyone. Thank you, Dr. Halawa, for this nice introduction. And I would like to thank the World Kidney Academy for inviting me to present some of the topics here about histocompatibility. And I hope everyone at the end of this presentation, you should be able to easily interpret it an HLA report or histocompatibility report. So without further, I will just start now.
Are you sure?
Yes, yes.
Do you think one webinar will be enough to be expert in the field?
Just like I have a housekeeping here, I think someone is starting to put annotation into my presentation, so just make sure not to ruin my presentation while I'm presenting, because I can see a red line now. So I would like to start this presentation with a very important hot topic question here is, who is accountable for the patient transplant rejection? And I have some questions here, and you can put your answer in the chat box, and Dr. Halawa can read it to me, and then we can proceed for the next slide. So is it the HLA lab responsible for that? Or it's the patient himself or herself if they are not taking... I'm sorry? Okay, is it the patient? Is it the coordinators or the nurses, the physicians, pharmaceutical companies, or all of the above? Anyone want to volunteer and put some answers in the chat box?
Mr. Kuma, all of them insist on F, all of the above.
Okay. I know why they put all of the above, because usually most of these, the attendant has done one of the board exam, and then all of the board exam are like that. So when they found all of the above, they choose all of the above. However, the answer is none of the above. And I will let you know why none of the above. No one is being blamed on a field rejection, and the reason behind that is it's not a one-man show. It's usually a committee that decide on the transplant. So this committee is usually formed of a transplant nephrologist, a transplant surgeon, a nurse coordinator, donor coordinator, and also the lab are heavily involved in this decision. And usually it's if there is a case where it's a borderline case or a gray zone case, we all discuss, and we now categorize this case, whether it's a standard risk or a moderate risk or a high risk. And usually the patient are informed about the risk of this transplant. So and that's why none of the above are responsible for rejection, because everyone is doing their own job. So at the end of this transplant round committee, usually the lab get the list from them on which patient they are going to proceed to do the risk assessment. So the purpose of today's presentation, I will show you some of the risk assessment that the lab do for assessing this patient. So how does the lab handle renal transplant patient? So as soon as we received the renal transplant patient, we categorize these patients into 4 groups based on the ABO blood group. And then we enter all the data information into the computer database. Then we receive a blood sample from this renal patient, and we do HLA typing, and I'm not going to discuss it in detail in this presentation, but if you are interested, at least you have attended one of the other webinars that I have presented in the World Kidney Academy, and you can learn more about the HLA typing. And then we also do HLA antibody, and the same as well. And both of these are entered into the database, and I will let you know why it's important to have a good database to input your HLA typing and HLA antibodies for all these patients. And then as long as these patients are on the wait list, so every 3 months, we collect a new serum from these patients, and we test for the antibodies in these patients. And again, if this patient received any blood product, and if they receive vaccination, or if they got infection or pregnancy, or if they have a failed transplant, all these information are added into the computer system. And then we actually ask for an extra sample after any of these sensitizing events, because you know that blood product is a sensitizing event. Vaccination itself is a sensitizing event. So after any sensitizing event, we receive another serum, and we test for the antibody, and then we put it into the computer system. So let's see why we do all this extra thing that we add to our computer database. So, and as I mentioned before, every patient or every waitlisted patient, we collect a quarterly HLA antibodies. So when they go to their dialysis, we ask the nurse to send us a blood serum, and then we collect and we test the HLA antibodies, and we put them into the HLA antibodies, we put them into the database or the computer system. So let's see if this patient is, for example, a lucky patient and they have a live donor. So what we do, we take also, we do HLA typing for the live donor. And if this patient is listed for only deceased donor, we also do HLA typing for deceased donor. And then we put all this information into the same computer system. So now the computer system have the HLA antibodies from the patient and have the HLA typing from the donor, whether the live or the deceased donor. And because of this information, now the computer system will try to find a possible compatible match to this patient by shortlisting. Like, for example, if we have a 250 patient on the wait list, not all these patients are compatible with their donors. So the computer system usually do a comparison between the HLA antibodies that the patient have and the HLA typing that the donor have. So basically, it tries to avoid the incompatible transplant by avoiding or by removing this all incompatible waitlisted patient. And at the end, the computer will generate a virtual cross-match report. And I will let you know what do I mean by the word virtual here. So this virtual cross-match will include all the possible waitlist patient that we predict to have a negative physical cross-match. So what is the virtual cross-match? So as I mentioned before, it's used to predict the result of the physical cross-match. So what we need from it, from the patient or from the recipient, we need the HLA typing of the patient, and we need the HLA antibodies that they have. And as I mentioned before, we collect these HLA antibodies quarterly, means every 3 months. And from the donor, we need the HLA typing or the HLA antigens that they have or that this donor have. And again, the computer compare between the antibodies and the typing and try to find a patient that does not have any antibodies against this donor. So this is, for example, a disease donor HLA typing. And you can see that this patient is typed as at the full loci A, B, C, DR until DPB. Now, if, for example, we have a patient, and here I call this patient XYZ. And these are the antibodies that this patient have. So what does the computer do it for us? It actually compares the antibodies that the patient have to the typing of the donor. So for example, here you can see that this patient have a CW12 antibody, and the donor also has a CW12 antigen. Again, this patient has DR1 antibodies, and the donor has DR1 antigen. Again, here DQ5 and DQ5. So at the end result, you can say that this is a virtual cross-match is positive. And why is virtually? Because we did not do any physical cross-match. We only compared the antibodies to the antigen. If we kept the same donor and we change now the patient, let's see what this scenario will look like. So now we still have the same donor, but now we have another recipient, and I call this recipient 1, 2, 3. You can see that this recipient or this patient have multiple antibodies here, like HLA 25, 26, 32, but none of these HLA antibodies is going to bind to any of these of the donor typing, because you can see here that the donor is A2, so none of them will be incompatible with the donor. And so what we call it, this case is a virtual cross-match is negative.
Do you mind, Professor Ahmad, just to ask our colleagues one question here, to see whether they manage to grasp the principle. So what is the essential prerequisite to do a virtual cross-match? On the chat box, what do you need to have to apply the virtual cross-match in your workplace? recipient typing or antibodies. What do you mean recipient typing? Let's just say A, B, C, and then DR. This will be enough. This is typing. HLA typing and AP recipient. I mean, ABDR, Asian, CPRA, recipient HLA antibody. I'm after one word, one magic word. Professor Ahmed mentioned and show it on the screen. HLA antibody of patient and child, quite understandable, but is it A, B, D, R are enough? DSA, what do you mean DSA? Again, it's D, P, D, R, A and B will be enough? Recipient antibodies. Full. The answer is, because I'm after the word full. Full HLA typing profile and full DSA profile. You can't rely on 3 HLA antigens and you say you can do virtual cross-match. You can't. But still you can have antibodies against DP, DQ, even HLA-C. Yes, Muntasir, this is fine. Yeah. So what you need is the full profile. Professor Ahmed, yeah.
Yes, yeah, excellent. Yeah, and this is actually is not my role. It's actually this is the UNOS or the United Organ Sharing Network, or this is the decision. And I'm pretty sure in UK have the same organization, and it become mandatory now to ask for the full HLA typing and HLA antibodies, and all this need to be done by molecular method, not by serological or CDC. So. I already showed you one example, but the computer system does not only look at one patient to one donor. It usually look at the whole wait list. So I can tell you here that the virtual cross-match, you can do it for both the deceased donor and also for the live donor. So let's talk first about the live donor. For example, if you have a patient and then, you know, when there is a renal transplant patient, you can see that there is a lot of sympathy happen within the family, and then everyone in the family wants to donate their organ to this patient. So you can see that sometimes this patient have 5 siblings, their mom, their dad, their aunt. All of them usually come to you as a nephrologist and then ask that they want to be a donor. So in order to pick which one of them is the best donor, is you have to do typing for all of them and compare the typing to this through and look at any one of this possible match to make sure that that patient does not have antibodies against this donor. And this is basically called virtual cross-match, because you will not ask the lab to do a physical cross-match for 10 donors for this patient. You have to select at least 1 or 2 and then ask the lab to proceed. The other function of the virtual cross-match is important for patients that they don't have any live donor. And these are the patients that are added to the wait list. And sometimes these patients can be in the wait list from 2 to 5 years. And for example, in our center, we might have like 250 patients on the wait list. And again, they are usually subgrouped by the blood group. So let's take this as an example. In the middle of the night, we received this donor in the middle of the night. So the first thing you can see in this donor, that this donor is a blood group OA. So when you add the typing of this donor to the computer system, it will start looking at the first match here, which is the compatible wait list based on the ABO. And then it will list all the possible A group, and then it will deselect the patient that have antibodies against this donor and will only give you a report for the patient that are compatible with this donor. And you can see here, this is just like a snapshot of a virtual cross-match with all these patients that are compatible with this donor. And there is other criteria for allocation here that we use, but I'm not going through all these details for this presentation. So as an HLA lab, we do consultation for immunological risk. And in order to assess this immunological risk, we usually do 3 major tests. The first is the HLA typing for donor and recipient, HLA antibodies for recipient only, and cross-match, which is either virtual cross-match or physical cross-match, which I'm going to discuss in this presentation. So the first, as a risk assessment, we do HLA typing. And since you are here in this presentation, you probably know the definition of HLA. HLA comes from human, and that's why it's called human, and leukocyte because all the initial experiment that was done on the early time of the field was done on white blood cells. But now we know that HLA is actually expressed on all nucleated cells. So every cell that have a nucleus will express HLA. So if I ask you this question, and you can put your volunteer answer in the chat box, what about red blood cells? Do you think red blood cells will express HLA? And I will wait for a second or a 20 seconds to put your answer. This is easy question.
Consistently, answers are no.
Okay, excellent. So my second question here, so don't waste your time. What about platelets? Platelets also does not have a nucleus. What's your thought? Does it express HLA?
One Dr. Salim M. Ben says yes, but others say no.
Okay, so platelets is a little bit tricky here. Platelets actually originate from the megakaryocyte, and the megakaryocyte is a large cell that was already nucleated. And then this megakaryocyte undergo fragmentation, and it formed the platelets. So the platelets actually carry the HLA from the megakaryocyte. And actually HLA is platelets is one of the major sensitizing events. So you can see a patient can take 1 or 2 unit in 1 or 2 units of platelets, and then they can develop massive amount of HLA antibodies. And this is what we call them platelet refractories. Platelet refractories mean that these patients become incompatible with all platelets. So you give this patient platelets and they start to form antibodies against their platelets. And then when you look at the platelets count in their blood, you will see that there is no increment or there is no increase within 1 hour of admitting platelets. And in that case, the only option for them is to receive a matched platelet HLA.
By the way, platelets.
So that's why it's very important to ask the patient what type of blood product they took, whether it's a packed red blood cells or whether it's a whole blood or whether it's platelets, because it's all depend on the plasma, on the expression of HLA antigen. I can see someone asking me about what about the plasma. Plasma will have a passive HLA, it might have passive HLAs, but it does not have cells. So plasma may result in transient increase of HLA if this donor plasma have HLA, but it is not a sensitizing event by itself. And again, you can see that the HLA is expressed on the surface of the HLA of the white blood cells, and that's why it can elicit an immune response in the form of antibodies. So
specific class, Dr. Ahmed, will you explain, is it class 1, class 2, or only class 1?
Sorry, Dr. Halawa, you mean a plate?
Platelets express class 1.
Oh, okay, yes.
A and
So
B.
platelets actually express class 1 mainly, and very, very low amount of HLA-C from the class 1, but mainly HLA-A and B. So when we do platelet refractories, we only test for class 1, and we only report the HLA-A and the HLA-B only. That's a good question. Thank you, Dr. Halawa. So there are two classes of HLA-A, HLA class 1 and HLA class 2. So HLA-A class 1 are formed of a one big alpha polypeptide chain, and you can see that the alpha polypeptide chain is formed of an alpha 1, alpha 2, alpha 3 subunit, and then there is a transmembrane protein, and then there is a cytoplasmic tail, which attach this HLA to the cell surface. The beta-2 microglobulin, when we in our lab, beta-2 microglobulin is not polymorphic. So if I type myself, type Dr. Halawa, and type everyone else, we are all share the same beta-2 microglobulin. So in the lab, we only do HLA typing for the class 1 because it's polymorphic. And I will show you a slide what do I mean by polymorphic. And the most common one that we test in the lab are the HLA-A, the HLA-B, and the HLA-C. For class 2, it's a different structure. It's actually formed of a one alpha chain and one beta chain. And it's a little bit different for class 2, which one we do typing for. But at this stage, we know that the class 2 are formed of HLA-DR, HLA-DQ, and HLA-DP. The alpha chain of the DR is monomorphic, or maybe you can find like 2 or 3 proteins now, but these are non-clinically significant. So we only do typing for the beta chain for the DR. But if you look at the DQ and the DP, both the alpha and the beta chain are polymorphic, and I will explain to you what do I mean by polymorphism in the next slide. And that's why we do typing for both the alpha chain and the beta chain for both the DQ and the DP.
Dr. Mustafa, could I just ask one question on behalf of our participants here? One question is, does the renal endothelium cell, does it express HLA in the same way as do the leukocytes? And the
that's an excellent question. So I mentioned before, any nucleated cell will express HLA. Is that question, you mean the same expression, the same level? If this is the question, no, they don't express the same level, but they express actually class 1 constitutively, and which means on their own they express class 1. Say, for example, you took these endothelial cells or these kidney cells and you put it in a tissue culture, and then you start to put a lot of cytokines or inflammatory markers, then these cells can also will induce to form class 2 as well. So when there is a kidney rejection, there is a lot of inflammation surrounding the media, and then that's why both class 1 and class 2 will be expressed on the kidney cells. Class 2 are expressed at lower expression than class 1, but when there are induced inflammation or anything, they induce very high amount as well. And again, the expression is different between different classes of class 1 or class 2. For example, DR have the highest expression, and then DP has the lowest expression. So sometimes DP is 25% expression from the class 2 or 25% from the DR. So what I mean here what do I mean by the word polymorphism? So this is actually a graph by year from 1987 up to 2022. And what you see here in the x-axis is the number of alleles of HLA that they have discovered during this time. So you can see here at the light green bar, which represent the class 1, we have almost, in 2022, we have 24,000 alleles. And if you can see here that we have for class 2, we have almost 10,000 alleles. So a total of 35,000 30,000 polymorphism. So this means that if I did an HLA typing for myself and try to find a matched unrelated donor, the chance is 1 over 30,000 to find a suitable match. And you can see that this polymorphism has changed based on the method of typing that you use. So for example, from 1987 to 2000, CDC or serology was the main method of HLA typing. And during this time, this was the only amount of HLA that they discovered. And that's why we say that serology is obsolete to do HLA typing now. And most labs now started to do molecular, because with molecular, you can look at the allele levels. And now a lot of the labs now has switched to next generation sequence, because now with next generation sequence, you can sequence the entire gene and you can find more alleles. The other thing also, when the field started early in the 1980s and 2000, they were focusing on the Caucasian population, so people from Europe or from North Americans. And that's why this population get the early numbers, like the A1, the A2, the A3. And then they moved into the Asian population. And that's why from the Asian population, they got the middle numbers, like the A24, the A30s. And then when they moved to the African, they were the last people to get typed. And that's why they got the later numbers, like the the B75, B80s, and so on. So from your HLA typing, we can predict your ancestors. So if you give us the HLA typing, we can put it into a computer program, and it actually can look for your ancestors. And that's why it's very important to ask about your race or your ethnicity when we confirming the HLA typing. And because we have now, and the previous slide was done in 2022, but if it's done in the 2024, we now have over 45,000 HLA alleles. And because of that reason, the HLA, the WHO made a committee, and they named this committee the HLA Nomenclature Committee. And in 2010, this HLA Nomenclature Committee had changed the way that you can call the HLA. Like, for example, in the past, if I found a new or a novel HLA in my lab, I can call it HLA Mustafa's, or HLA Mustafa 2, or HLA, and then another lab in California find the same gene that I found, and then they call it HLA California 3. So the HLA Nomenclature Committee actually took all these HLA and they started to organize it so that we all speak the same language. And they put certain rules in how you have to name this HLA. So for example, here, this is you first have to put HLA, which is human leukocyte antigen, and then you put a hyphen, and this is very important. And then you put the gene. For example, here, in this example, I put the A gene, but you can put the B, the C, the DR, the DQ, and the DP. And then you have to put a separator or an asterisk, and then it's followed by a number. This number represents the serological equivalent of this antigen, because in the early experiment, they were done by serology. And then when they started to do molecular, they found that some of this protein have subtypes which can be detected by the molecular techniques, but cannot be detected by the serological techniques. And then there is a third number which represents a silent mutation in the gene, but until 2024, the third and the fourth field are not clinically significant. So although we do the typing for the 4 fields, we only report the first and the second field, and I will tell you why. And here, as you can see, the 4th field represents mutations or different substitution in the non-coding region, but I'm not going to further details here. And then sometimes you can find the letter, and this represents the level of expression. Sometimes you can get low expression or null, which means that the gene is present, but the gene is not expressed at the cell surface. But what I want to focus on is the first number. And if you see the first number, in the lab, we call it low resolution HLA typing. If you see the second field, that's what we call high resolution typing. And I can actually stop for a minute to see if anyone have any question before I proceed to the next case here.
What would you, how would you explain silent substitution, Dr. Mustafa? Can you
Okay,
expand on that?
silent substitution means it's something, there is a mutation that happened at the gene level, but this mutation does not result in a formation of a new amino acid. Like, for example, there are, when there is something, if you go back to the biochemistry, you can know that in order to form one amino acid, you need 3 codon. So, for example, U or uracil can form phenylalanine. But also UUG can also form phenylalanine. So although you can see that there is a mutation at the genetic level, this genetic level did not result in a new protein. And that's what we call it silent. Silent means it did not result in a formation of new protein.
That's a wonderful explanation, Dr. Mustafa.
2 questions. What about CW in class 1 from Dr. Sayed? Another question.
I'm not sure if I understand this question. What does, I'm not sure what do you mean by what
What do you mean,
what
Dr.
about
Sayed,
from
but
what?
what about CW in class 1? Is it
Like from what?
clinically
from what
relevant or not?
perspective?
Or, you know, anyway, another question here from Dr. Muhammad Hassan. HLA B5 between brackets HLA 51, 52. Why?
Okay, Dr. Hassan, can you wait for a minute? I will explain the problem
this will come later,
in a second. And I see a good question here from Ben Lomi about the pack red blood cells. So this is like after 1995, I guess, it became a mandatory that all red blood products to be leukoreduced. Leukoreduced means that they remove all white blood cells from the packed red blood cells. So the efficiency of removing the white blood cells is like 99.9%. So there is still 0.1% chance that this packed red blood cells contain very, very, very minimal amount of white blood cells. So it usually depends on the amount of packed red blood cells you are taking. Like if you are taking 20 packed red blood cells, and then you look at the cumulative amount of this white blood cells, so it's still considered a slightly sensitizing event, but for sure it's not the same as if you took a whole blood. But I don't want you after this presentation to say, yeah, it is safe to take red blood cells. Again, it is the efficiency of removing white blood cells is not 100% efficient. So still you have to be cautious when you do that. The other thing, it is very personalized. What do I mean by personalized? Means sometimes you can see a patient takes 20 packed red blood cells and nothing happened, no sensitization. And you can see a patient just passing the blood transfusion bank without even taking any blood. I'm just kidding. And then you can find that they have massive amount of HLA antibodies. So again, there is a big personalization in this factor.
Sometimes in Sheffield, we ask for HLA matched blood.
Exactly, yeah. In cases, yeah, but that's very difficult to find. But yes, it's usually you have to go through a registry donors, and you have to go search for it worldwide. But yeah, that's the possibility.
Fine. Let's move on, Dr. Ahmed.
Okay. So what do we do in the lab? And I already explained this in other webinars, so I'm not going to do a lot of discussion about the HLA typing. But basically, we receive the blood, we do DNA extraction, and then depend on the level of resolution that we do. So if we are going to do a low resolution typing, we use the real-time PCR or the SSO. And if we are going to do high resolution typing, we do it by sequencing. And I'm not going to do much details here. And then we review, and then we report. So let's look at this case study, and to make sure that you understand the concept of what I mentioned previously. So this case study, and actually this is a real case. Basically, the top row here is the typing of the patient. So the patient is A1, A30, B41, B44, and DR4 and DR11. And for simplicity, I just removed the extra typing. And this patient had two possible donors, donor 1 and donor 2. The patient have HLA-B44 antibody with a mean fluorescence intensity of 10,852 MFI. So my question is, who will be the best donor for this patient? Is it donor 1, donor 2, none, or both donors are okay?
None, 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 none. There's consensus here about none.
Okay, so I will challenge you again here. So this is a case that came to me, and then the nephrologist asked me about my opinion. So I informed the nephrologist that we need to do more extra testing to see what's going on with this patient. So the first challenging here, look at the patient is B44. The patient also have a B44 antibodies. Is that possible that the patient develop B44 antibodies against themselves? So let's see how this happened. So when this case came to me, I said to the nephrologist, we need to proceed with a high resolution typing, because with this information, I am not able to tell you which donor is the best. So when we did HLA typing high resolution, it came like this. So the patient was actually a B4403, donor 1 was B4402, and donor 2 was B4403. So donor 2 was matching patient. The patient had a B4402 antibody. So the patient developed what we call allele-specific antibody. So before you rush and say none, and then now you are excluding a high possible donor for this patient, and then this patient can wait for another 5 years in the wait list, you have to do your best to make sure that this patient can get every possible donor. So the answer for this question now has been changed after we did the high resolution typing. So in that case, it will be donor 2 is the best. Sorry, I think this is, yeah, I'm right. Donor 2 will be the best donor for this patient.
Actually, Professor Ahmed, we have very good answers here from Serena. High resolution. Yes, well done. And then
did she see my answer before she responded?
no, honestly, no,
Okay.
no.
Okay.
Well done, Serena. Well done. Yeah, and she said donor 2.
So next very practical question which comes up, would you do high resolution typing every time, even if a patient may not have antibodies?
So like in my lab, we do high resolution for everyone now. The only time when we do low resolution is during on call. And this because we need a quick HLA typing, which can be done in 90 minutes. But now it become mandatory in our center to do high resolution typing for everyone. I know that some centers cannot afford it, but at least cases like the one I presented here, you need to do it high resolution typing, because without high resolution typing, you would ignore or you will decline these two offers. So sometimes, yes, you need to, there is no way that you can escape high resolution typing. Okay, let's move on. So the next thing or the next risk assessment that we do in our lab is HLA antibodies. And HLA antibodies are usually named according to the antigen that they bind. For example, this HLA antibody is going to bind to the A1. So now this is called HLA-A1 antibody. This HLA is going to HLA antibody going to bind to the DR7. So now we call it DR7 antibody. This one is going to bind to the CW9, and so we call it CW9 antibody. However, I actually lied on you because HLA antibody does not bind to the antigen. HLA antibody bind to a specific part of the antigen called the epitopes. So here you can see that this HLA antibody is going to bind to the yellow epitope. And this is very important because sometimes you can see shared epitopes between different antigen. And that's why it depends on which epitope is going to perfectly fit the antibody. It's the same idea or the same theory as the lock and the key. The key has to be match the lock in order to fit properly. So let's take this as an example here. So if we have 4 different antigen, HLA-2, 23, 24, and 68, you can see here that if a patient develop HLA antibodies against the star epitope, and all these symbols are different epitopes. So if a patient develop an antibody against the star, which is an epitope expressed on the A2, the same antibody will recognize the 23 and the 24. And again, if this patient develop an antibody against this purple, the antibody will recognize this one, and so on, and so on, and so on, and so on. And you will end here that have some epitopes that are only shared in one antigen. And this is what we called allele-specific antibodies. And this was exactly the example that or the case study that I have shown you previously, which was 4402 and 4403. So although 4402 and 4403 belong to one broad antigen, which is the 44, but they can form 2 different antibodies against the 4402 and antibodies against the 4403. And it is very safe to cross this type of allele-specific antibodies. And the idea of this cross-reactivity is not simple as I have shown you in the previous slide. So if you are going to write your board exam, you need to memorize all the cross-reactive group by heart because they ask you a lot of questions in the board exam. And they actually divide them into different groups here. So the A1 Craig, the A2 Craig, which is a bunch of antibodies that cross-react together. And again, there is the B5 and so on. And I'm not going too much into these details in this presentation. So let's take an example of a patient here. This patient is typed as A29, A36. Please, Dr. Halawa, if there is any interesting question, you can stop me. And if there is anyone in the chat box, because I cannot see the chat box as well.
No, carry on. Carry on. Carry on, the Professor Ahmed. Everything's fine.
Okay, so if we have here a patient who is A29 and A36, B59 and B52, and this patient have a donor who's A29 and A2 and B27 and B59. So you can see that this is mismatched at the A2 and the B27. So if this patient going to lose the kidney, or for some reason this patient got Becky virus and we have to reduce the immunosuppressive, there is a high chance that this patient is going to develop an anti-A2 and anti-B27 antibody. But the picture is not very simple as I'm showing you here. Basically, because of the cross-reactivity, this patient will develop all these antibodies because they cross-react together. And again, for the B27, they will develop all these antibodies. So from two mismatches, you can find that the CPRA of this patient become 88% from just 2 antigens. And why we usually care about an antibody? So because I've seen a lot of questions asking about kidney cells express HLA. So what you see here, this is a cross section of an HLA, from a cells from the kidney. You can see that it is nucleated, so it's expressed HLA. So if a patient develop a donor-specific antibodies against this HLA, This will finally activate the complement system, and this complement system will activate other complement cascades, and this will result in what we call membrane attack complex, and then this is what we call a classical pathway for antibody-mediated rejection. In the lab, we identify this by looking at the donor-specific antibody and by looking at the pathological biopsy and looking at phenotyping or immunostaining for the C4D. And this is how we diagnose a case of AMR. So AMR actually are three different types. The first one is the hyperacute rejection, which actually can happen minutes to few days. So, and this is usually transplant surgeon, and Dr. Halawa can correct me if I'm mistaken. Once you put the kidney into the patient, the kidney can turn blue and become with no urine and become hyperacute and rejected. We rarely see this case because it's going to be shame if we saw it, because we screen the patient very well. We make sure that the patient does not have any antibodies against the kidney before we transplant. In rare cases, if you are going to do an AB incompatible transplant, which some centers do, they might see these cases more frequent than the others. The most common one is the acute, which can happen between a week to a year. And this is due to the formation of de novo or new donor-specific antibody, and also the gradual loss which happen after, or the chronic, which happen after a year. And we usually see this with patients who are not adherents to their immunosuppressive, especially patients who are pediatric, and then they go to their teenager stage. And when they see their friends not taking not taking medication and living their life, they start to want not to take their medication. And a lot of these teenagers come to the clinic with chronic rejection because of adherence of their immunosuppressive. And we do our best not to see this happen in the theater. So this is the main reason, or this is the main risk assessment that we do in the lab. So for HLA antibody, we receive the serum. We use the Luminex assay to detect the HLA antibodies, and then we report this HLA antibodies. And I'm not going to do details on how this works, but if you are interested, you can watch the other webinars. But I want to focus here on the two types of screening of antibodies. So there are two different types. There is the screening, or some centers call it the PRA, and there is the other one, which they call it the single antigen bead. So PRA here is the kit that we buy from the vendor or from the commercial kit. Each bead has different flavors on it, so different flavors of class 2. And for class 1 beads, you can see also that the one bead have a different flavor. So the same bead has multiple HLA expressed on it. So when we add the serum to it, it will only tell us if this patient have a class 2 or a class 1, but it will not specify which type of class 1 this patient have. So for example, here you can see that this patient developed antibodies against the yellow flavor here of the class 1. So when we give the physician the report, we can tell the physician that the patient have class 1 antibodies, but we are not supposed to give them the specificity. If you want to know the specificity, then we go to the single antigen beads. And the single antigen bead, you can see that each bead now have one flavor. So for example, the DQ1, which is the old name of DQ5 and DQ6. Here you can see that it is now the A28, which is the yellow flavor, which is matching here. So now we can give the patient or the nephrologist that the patient have an HLA A28 antibody, and the DR1 here and B60 here. So we usually do the screening first because it's much cheaper. Like for example, in our center, the screening cost us like $25. But for the single antigen bead for class 1 is $300, and for class 2 is $300. So a total of $600 to do the single antigen. So we only do it for cases that need to do single antigen beads. So how do we get sensitized by HLA antibodies? There are different ways to get sensitized, and the most common is if you receive a foreign transplantation or pregnancy, because you can see here that the infant carry half of the genes or half of the HLA from the dad and half of the HLA from the mom. So the mom can become sensitized against her own child. And then now this pregnancy, multiple pregnancy, can result in formation of HLA antibodies into the mom. And I have seen cases with just like multiple pregnancy that this mother become a CPRA of 95%. So let me ask you this question here. So if you have these two pairs and one of them want a kidney from the other, who will be the best donor to give? Is it better for the wife to take from her husband, or is it better from the husband to take a kidney from the wife? Which one will be the best donor if these two pairs need a kidney?
Wife to husband is one answer. Husband to wife.
I can see someone here asking, yeah, so when you say wife to husband, yes, yeah. So rule number one in transplantation, females are more generous. So that's true, because now the wife have developed antibodies against her husband through the pregnancy. So now if you give her, if the wife took a kidney from the husband, she is most likely going to have antibodies against her husband.
Actually, Professor Ahmad, they are always generous, even in life.
Okay, you are more political than me, Dr. Halawa.
No, this is reality. You know, in the transplant unit and where I work with, most of the living is wife to husband.
Yes.
Yeah.
And they also are more courage than the female than the males when they come to transplant. You're right. Yes.
All respect,
other-
ladies.
Yeah. The other sensitizing event, transfusion, which I mentioned already, vaccination as well is a sensitizing event. So let's take this case study and discuss it together. In 2020, the patient was typed in a lab A. I'm not going to give any names, just lab A. And this lab give the patient the following typing: A1, A19, B41, B12, DR4, DR5, DR52, 53, and then DQ3. And just for simplicity, I only added this typing. And then this patient went to the nephrologist, and the nephrologist said, oh, I don't trust this lab. Let's repeat the typing again. So they sent it to a different lab, and actually the result were discrepancy, as you can see. So the patient was type A1. The one in red is the discrepancy here. B44 instead B12, and then DR11 instead of DR5, and then DQ7 instead of DQ3. So you can take a picture of this before I proceed, because I'm going to ask you now a question. So my question.
These labs are not. Sorry to interrupt. These labs were not in Canada or in Europe or anywhere else. Actually, it was in the Middle East.
Okay, thanks for this exposure, Dr. Mahal. Okay, so which of the following options best represent lab discrepancy in this report? A, lab A is correct. Lab B is correct. Both lab A and B are correct. Both lab A and B are wrong or incorrect. Any clue?
We got lots of answers here. C, 1A, C.
Oh, if everyone is going to answer C, then I'm not going to continue the presentation. I think
I mean,
all profs
I am
here.
impressed.
Okay, so without, yeah, excellent. I can see here serology versus molecular. Excellent, excellent, excellent. Okay, thanks. Okay, so to be honest, yes, the short answer, both lab A and B are correct. But I want to stop here for one reason, and I'm going to explain you why they are correct technically, but they are not correct because the lab A typing was done by serology, as you already know, and they reported the broad antigen. Broad antigen, we are not supposed to report broad antigen because the correction or the definition, the true definition of low resolution typing, a low resolution HLA genotype is defined as sufficient to assign genotype to the level of serological split. So although both of them are correct, but lab B is more correct than lab A because lab B went to the split level, which I'm going to explain it in the next slide. Okay, so what is broad versus split? So for example, back in the 1990s or the 1980s, they found a new antigen. And why they call it a new antigen? Because they found a new antibody, excuse me, they found a new antibody that bind to this antigen. This antibody did not bind to the previous 18 antigen that they discovered. And because this antibody did not bind to the previous 18 antigen, they called the new antigen HLA-A19. Now we know that this is called the broad A19 antibody. And why now it's called broad? Because 5 years later, they found a new antibody that were able to split the A19 into 2 groups. And that's why it's called split, because it's actually splitted the A19 into 2 groups. Group 1 was able to bind to this antibody, and group 2 was able to bind a different antibody. And then when they took the same antibody, or they took this antibody and tried to put it to this group 1, it did not bind. And when they took this antibody and put it to the other group, it did not bind. And now, because the next numbers were already occupied, the 20, the 21, and so on was already occupied, so the next number available in sequence was the 29 and the 30. So, and that's why the old name is the A19, the new name is the 29 and the 30. So if you see a report coming to you as A19, please do the same as the previous doctor have done and ask the patient to repeat the typing in a more recognized or a more lab that can recognize between the broad and the split. And now this has become the A29 and this become the A30. And you can see here, it's not only the A19, there is a bunch of broad antigen here that become the split. So for example, the A9 become the 23 and the 24, the 19 become not only the 29 and 30, but later on they found other antigens as well. And I remember someone was asking me about the B5, which become the B51 and the B52. So the B5 is the broad and the 51 and 52, the split. And this patient was B12 in the first lab. Now it is B44. And also at the class 2, the same as well. In the first lab, they reported the patient as DR5, but when they did the split, is DR11 and 12. And also they reported the DK3, which become the 7, 8, and 9, and so on. So let's come to the last part of my presentation today, which is the cross-matching. And this is, I already explained to you earlier what is the virtual cross-match. So now I'm going to focus on the physical cross-match. So for the physical cross-match, you need to have, there are actually 2 types. There is something called the allo cross-match. And the allo cross-match is basically you are crossing the patient's serum with the donor cells. For the auto cross-match, you are crossing the patient cells with their own serum. And I will explain it more in the next few slides. What do I mean by auto cross-match? And when do we need to do auto cross-match? So let's focus first on allo cross-match. So in allo cross-match, basically you have your patient serum, you have this patient serum have multiple antibodies like brown and green, and you have the donor lymphocyte. And I will ask you in the next slide why we choose the lymphocyte to cross it with the patient serum. So for example, here when you incubate the patient serum with the donor lymphocyte, you can notice that only the brown antibodies bind and the green did not bind. And the reason the brown antibody bind and the green did not bind, because the donor cells have an antigen that is compatible or actually binding to this antibody, and it did not bind to the other antibody. And this is what we call donor-specific antibody. So in order to identify this antibody, we cannot see it. Like if an antibody binds to a cell, we cannot see it by our eye or by the flow. So you need to put another antibody that has what I call a fluorescence dye. And this antibody is called the secondary antibody because it's going to bind to the primary antibody. And if it bound to the primary antibody, we now can visualize it by looking at the fluorescence tag attached to this antibody. And then in order to differentiate between whether it's a T cell or a B cell lymphocyte, we add another antibody that has a fluorescence tag to it, and it has a marker. So for example, the CD3 will bind to the T lymphocyte, and CD19 will have this other fluorescence which bind to the B cells. So if you see like two dyes, like if you see the red and the green, you can tell that this patient has a B cell positive cross match. If you see three dyes, like for example, the yellow, the green, and the red and the green, now you can say that this patient have both positive T and B lymphocyte are positive. So I'm going to ask you a few more questions here to make sure that you understand the concept. So the first question I actually answered to you, so for the sake of the presentation here. So why we use T and B lymphocyte? Like why, for example, we don't use the granulocyte? Why we don't use monocyte? Why we don't use neutrophils, for example, for cross-match? They all express, because the reason we use the T and the B cell lymphocyte, because they have massive expression of HLA. And because they have massive expression of HLA, they can increase the sensitivity of our assay. This means that if you have very small amount of antibodies in your serum, but you have massive expression of this of HLA antigen on the cells, then this will result in identifying this very small amount. So that's why it will increase the sensitivity of the assay. My next question here: which HLA is expressed in T cells? Let's pause for a second here. T cells is nucleated, right? So by rule number one, nucleated cells will express HLA class 1 only. Then let's see the next question here. Which HLA is expressed on B cells? So class 2 are constitutively means without any further stimulation. It is expressed on 3 types of cells. The first cell is B cells, macrophages, and dendritic cells. These are the only 3 cells that express both class 1 and class 2. I know that some people ask me, what about kidney? Yes, kidney can express class 2 when they become inflamed. Endothelial cells, sometimes they become constitutively expressing class 2 because of the cytokines surrounding it. So, but these are the only cells that express class 2 without any stimulation. So here is my question here. You got the result from the lab telling you that this is a case of a T cell positive, B cell positive cross match. What does that mean? Look at number 2 and 3 and put your answer in the chat box. If you got a result saying that this patient is both positive for T cells, I can see Dr. Ali saying class 1. Any other question? Any other response? I see comma, anti. Okay. I'm seeing better responses now. Oh, excellent. Okay, excellent. Okay, so let's explain this again. T cell positive, B cell positive cross-match means, first, it could be class 1 only, because both of them are nucleated, but also it could be both class 1 and class 2. So here I only put both class 1 and 2 are positive, but sometimes because B cells is also positive, so here I'm missing one more answer. It could be only class 1, and it could be class 1 and class 2. So both answers are correct. So next question here. The T cell is negative, but the B cells are positive cross-match. What does that mean? Class 2 only, yeah. Low level. Okay, so in the normal scenario, because I see people say could tell me low level. So B cells actually express only actually express class 1 and class 2. The T cell negative here is because there is no class 1, but I can see someone here ask me, or actually put the question, low level of B cells, low levels of B class 1. So yeah, B cells actually express more class 1 than class 2. So in very, very rare occasion, but I don't want you to go to this rare occasion, it can identify that this patient had very low levels of class 1. But usually, and that's why we don't depend only on cross-match in the result. We have to look at the whole picture. We have to look at our single antigen beads, and we have to look at the cross-match. So if we see something like this, it's very good as a consultant in the lab to go back and look at the single antigen beads to make sure that there is no low levels of class 1 expressing again. But in 99% or 90% of the cases, it is because it is class 2 are positive. So now if we have a T cell positive and B cell negative, what does that mean?
Yeah, some people
I
say
see
error.
people are presenting error. I don't know. Do you think that all the lab are doing a lot of errors? Non-HLA, okay. Error, immune problem, yes. Only class 1, false positive, rituximab, B cell negative. Rituximab, I will just take this, okay? What do you mean? Okay. Okay. Might do, yeah, I think there are some good answers here. Excellent, excellent. Lab error, okay. So for people who said lab error, I would tell them thank you about it.
No, just I would like to, to make a note on this. I mean, the lab, when is not sure, will repeat the test more than once. We spend 4 to 5 hours waiting for the cross-match result. So we're not expecting any error after all this repetition. So don't put it down as lab error, because you don't do mistakes.
So let me, yeah, I think, yeah, I know a lot of people maybe have.
I would say slightly differently, errors can happen, but because of very high quality internal and external quality control, it should be minimized.
I like
Is that
Selena, non-specific HLA. Well, yeah, I mean, we have very excellent answer.
Okay,
So Professor Abbott.
Okay, so here the question is, more work is needed, and you already answered this question, Dr. Halawa, and I will put much more details here. We need to know, does this patient has autoimmune disease? Because sometimes autoimmune disease can react with T cells and does not react with B cells, so it gives you a false positive reaction. And I can see people also here have put some monoclonal antibodies. They put rituximab, but rituximab will revert the picture. Rituximab will give you a false positive B cell, but not a false positive T cell. But I have seen a patient This patient had psoriasis, and psoriasis is an autoimmune disease, but the skin doctor or the dermatologist was treating this patient with anti-TH17 monoclonal therapy. And TH17 monoclonal therapy is one type of the T cells. So it binds to the T cells and it results in a false positive T cells. And this patient, just because of he's taking this monoclonal therapy. Sometimes vaccination itself, recent vaccination can alter the HLA present on the T cells and then now they become sensitized. Yeah, lupus also can cause this because lupus is an autoimmune disease. So yes, it can
Also,
cause this.
non-HLA antibodies, especially if there is no GCA reported.
Yes. So in that case, the lab need to do further testing. The lab need to do auto cross-match, and the lab need to confirm it by a surrogate cross-match. And I'm not going to explain the surrogate cross-match for this presentation, but I will explain what is auto cross-match because I promised you at the beginning that I'm going to explain auto cross-match. So we don't, like in our center, we don't do auto cross-match automatically for each one. I know there is other center that they do it automatically, but we don't do it because not every patient need to do this extra testing. We only do it if we find an unexplained physical cross-match. So in that case, for example, a positive T and a B cell cross-match in the absence of donor-specific antibodies. And that's why I'm telling you, you need to look at the whole picture. Don't just focus on cross-match because, you know, first cross-match is a cell-based assay and it can result in a false positive reaction. It also can result in a false negative reaction. So you have to see the whole picture. And this is when we ask for an auto cross-match. Autoimmune disease, as you mentioned, systemic lupus, insulin dependent. Yeah, I've seen a lot of patients who are insulin dependent diabetes that give you false positive cross-match. Celiac disease is still an autoimmune disease, and it can result in false positive cross-match. People who are taking some medication, so anything which ends with a MAB is mostly considered monoclonal therapy. Rituximab is the most common because most of the patient, or not most, but a lot of the highly sensitized patients are taking, or patients who are systemic lupus also take this medication. So in that case, we need to do auto cross-match. Auto cross-match means we are crossing the patient's serum with their own cells. So if the auto cross-match come positive, we will know that the patient have something in their serum that is reacting with their own cells. So in that case, we cannot use the cross-match as our conclusion to proceed to transplant or not. In that case, we will go backward and will depend on the virtual cross-match. And that's why a lot of the lab in the US and Canada has now opted out of using cross-match and depend mostly on physical cross-match, on virtual cross-match, because the Luminix assay become now very, very sensitive that can tell you if this patient is going to be predicted to be a positive or a negative cross-match. And there is a lot of published papers showing the accuracy of the virtual cross-match to be above 95% compared to the physical cross-match. So what causes false positive cross-match? Sometimes sample transportation, like for example, in Canada and maybe probably in UK in the winter, excessive cold, but in the Middle East, usually hot temperature can also result in a sample become some sort of denaturing happening. Like for example here, this is a cell, like white blood cell, and you can see it is beautifully expressing the HLA class 1 here because you can see the beta-2 microglobulin is nice, the alpha chain is nice, and you can see that the antibody or the HLA antibody is binding perfectly to this HLA antigen. But sometimes, because of the excessive cold or hot, sometimes this HLA become denatured. What does denatured mean? Denatured means that you can lose a small part of the HLA molecule. Like, for example, if you lost the beta-2 microglobulin, now the folding of the HLA will change. And because of the folding change, it will expose some of the hidden epitopes. Remember the epitopes? The definition of epitopes, it has to be on the cell surface for the antibody to bind. But now, because it's unfolded, some of the hidden epitopes become exposed, and it will result in non-specific antibody to bind to this HLA molecule. And here, for example, this antibody is starting to bind to the beta-2 microglobulin because now it lost the main molecule, and now a new epitope become exposed here. So this is what we call denatured HLA molecule. The other thing also, if a patient has received a vaccination, or this patient have some sort of viral infection, these viral particles will be expressed on the HLA molecule, and because it's expressed on the HLA molecule, it sometimes act as a hapten, and it can bind to the HLA antibody, but it's not harmful. And sometimes it results in what we call a false positive. So the reason I want you to make sure, because I know Dr. Halawa mentioned the word non-HLA antibody. In the past, when I used to report this report to the patient, to the physician, I used to the word non-HLA, but now I use the word non-specific because I found it is actually better fit than non-HLA. And I will tell you in a second why I think non-specific is a better fit here. Because now there is a bunch of non-HLA and sorry, is there a question? Okay, because now there's a bunch of non-HLA antibodies that are available, and there are some clinical tests that they use. Although most of these tests are not clinically available, but the most common non-HLA antibody that we test is the AT1 receptor, because this is clinically available. And there is a lot, not a lot, but there is a percentage of patients that become rejection because of the AT1 antibody rejection. So with the pathology, you can see a signs of AMR, or antibody-mediated rejection. When you test this patient for donor-specific antibody, there is nothing. And now there is usually a discrepancy between the HLA lab and the anatomical pathologist, and they usually say, oh, who is right and who is wrong. But when they test for the presence of AT1 receptor, then they find that the patient has AT1 receptor antibody. And it's not only this, there is a lot of other non-HLA antibody like the IL-18 receptor, the CXCL11, and a bunch of other hits, but they are not very clinically significant. But if you are interested, there are a lot of labs that they do it for research purpose only. And I know some people also ask about rituximab, and here rituximab is an anti-CD20 antibody. And because it's an anti-CD20 antibody, the CD20 is also expressed on the B cells. So if a patient is taking this monoclonal therapy, it will actually bind to the B cells. And then when you add your secondary antibody, it will detect this rituximab. So it will give you a false reaction. And make sure here it does not react to the T cells, because T cell does not have or does not express CD20. So patients who are taking rituximab, you will mostly see a B positive cross match. But I will stop for a second here, because if you're going to do an auto cross match to this patient, it's going to be inconclusive, because this patient will not have B cells in their circulation. So when you ask the lab to do an auto cross match, the lab will give you the result as inconclusive, because the patient does not have B cells in the circulation, so they cannot proceed with an auto cross match. So if the patient does not have B cells in the circulation, if the patient have a B cell positive cross match in the absence of donor specific antibody, then the only way to transplant this patient is to look at the virtual cross match and proceed if you think this virtual cross match is negative. It still carry a little bit of risk, but it is better than declining all other offers as well. So I will summarize my presentation by the following statement as a pre-assessment. In the lab, we don't do HLA match for everyone, but we make sure that everyone is compatible. Same as a donor of blood group O can give a patient A and B blood. And so the reason here we do compatible, same idea as the blood group as well. We need to avoid antibody-mediated rejection, because once it happens, it's very difficult to treat. And so we pick a recipient who does not carry HLA antibodies against the donor HLA antigen. And we do our best to make sure that that our wait list don't miss any opportunity, and at the same time to have a safe and successful transplant. So I started my presentation to ask you who the one you're going to blame, and you said all of the above. Actually, if we did all our job, then the typical answer will be none of us are going to be responsible, because every one of us did their own job. At the last here, I would like to thank you for listening, and I'm very sorry if I took more than my available time. And if you have any question, I will stop here and I will be ready to answer your question. Thank you.
That's an amazing presentation.
Everybody,
Yes.
hello. Yeah. Thank you very much, Professor Ahmad, for this, very extensive review of the HLA and cross matching. I would like to remind everybody there's still another presentation where we'll discuss 3 clinical scenarios. So, but we have to be quick with your questions, please. Otherwise, we'll be running out of time.
Yeah, one question is I'm just reading from